I think that's critical because you're talking about a disease that patients live with, right? And if we're in the office and we're treating these patients, we get a snapshot of their lives, but then they have to go home and live with their lives, with their families, their loved ones, their friends, and still do the day-to-day activities. That's the reason we treat patients. So if we can give them intense therapy and shrink tumors on scans, that's only part of the story. We need to make sure that not only can they live longer, but they can live well while they live longer. So when we analyze the data suggesting that patients on the therapy on the JAVELIN Bladder 100 trial, as I said, those patients got chemotherapy and then got immune therapy maintenance. Once they were on the immune therapy maintenance, hopefully for a very long time, for those that did really well, they didn't have that much toxicity. The rate of developing severe adverse events to the therapy was low, under 5% after a year on treatment, which I think is a pretty remarkable and a testament to if you're going to respond initially to that treatment, hopefully you can not only stay on that treatment for a long time, but stay on it living well. The others that we showed was, in VHL syndrome. We talked about how surgery can be a huge quality of life impact. When making a decision for that patient in front of you, are you going to take them to the operating room or are you going to put them on a systemic pill? How do we make those decisions? It has to be a discussion with our patients. It can't just be numbers on a slide or numbers in a pamphlet, right? It has to be what works for you, what's your job, how is this going to impact your day-to-day life? And then we can provide the best options for our patients and counsel them into making the decisions that's right for them.